All right. So again, welcome everybody, and welcome to our event today, the 15th of October, 2022. And today we also are dedicating our meeting to a level of awareness. One thing that has been plaguing, and she will come with some facts and figures in a moment, but has been plaguing a lot of people, and even from the African descent, has been breast cancer. Either men, women, or any gender, it doesn't matter. Professor Egondu Onyejekwe. Onyejekwe, there you go. She of course is a scholar and a gift in our community here. She'll talk about a few things. I met her with, as she started running with the foundation, and she'll tell us the story behind that. But she's definitely a great resource. She's going to actually share with us today. She also has, I believe, Dr. Debo Awosika-Olumo also, that will also chip in, so that, like I said, it's not a woman awareness. We also have some info on the men's side. But she will be sharing with us today, very informative. And Professor, feel free to share your screen and we'll shoot up here for us to see. But again, feel free to ask our questions after this. We really appreciate your time with us. Welcome, Madam and Sir. I'll hand it over to you.
Okay, hopefully you are all well and ready to hear what we have to say. My colleague, Dr. Awosika, is here all the way from Houston. I invited him because I'm going to be talking about breast cancer for women, and he's somebody who has experience with prostate cancer. And I think that since there are men here, also that you may have hear a word or two from him. But Buki, can I share my screen?
Go ahead, ma'am.
Okay, thank you. Okay, this is my screen for today, and it's in reference to the Breast Cancer Awareness Month. And I know you people just finished a meeting right now. So can you stand up for just 1 minute? 1 minute, I'm not taking any more than 1 minute. And exercise, stretch your hands to the sides, bring to your breast. To the sides, bring to your breast. Up, bring down. Up, bring down. Up, bring down. Okay, that's it, see? It wasn't that hard, was it? What was it? So what I wanted to make sure of is that you're all awake for one thing, and there isn't much interactivity here because I'm going to be speaking, and then Dr. Awosika will speak, and then before we get to question and answers, so I wanted to have some little participation also. So anyway, as I said, is the Breast Cancer Awareness Month. Future presentations will have to go in detail inside the breast cancer itself, the disease itself. This one is particularly just informational, okay? And I'm going to focus on it. And then when we go into the details in future months or future iterations, I'm going to also include cervical cancer. But today, the take-home message is being aware, knowing what to do, and go and get screened for breast cancer. Man or woman, it doesn't matter, but mostly it's for women. So without further ado, I'm going to start. I started, oh yeah, I want to apologize for not showing up on the 1st of October, Nigerian Independence Day, because I was trying to set up this foundation on breast cancer advocacy with cervical cancer. And I found that since I'm not teaching anymore, I don't have students who can do some downloading and copy and paste and stuff like that. You know, there wasn't help. So just pure administrative overhead overwhelmed me. It was too much, and I couldn't edit the site. I mean, the site was operational, but I couldn't have the time or people to edit it in time for you to interact and do stuff at a time. So I had to pull the whole thing down. And I said that the foundation itself, setting it up and creating all that website and everything and all those interactions is still separate from advocating for breast and cervical cancer. And that I will still present you with the opportunities to see what the deliverables are over and above what a nomenclature of foundation is. So that's why, and I do apologize. I didn't want people to get entangled, and then all of a sudden I bring it down and say it is no longer functional. And so I hope you all forgive me. But as I promised Mr. Buki, I said I would come to your third Saturday in the month meeting, and here I am. So this is what we're going to talk about. And I'm going to take this actually up here, maybe out here. So this is what we're going to do. I'm going to introduce the subject matter as I have already started and tell you what I'm going to talk about. Then I will talk about what I'm going to talk about. Then I will tell you what I talked about that I told you I was going to talk about. So that's the agenda for the day. And my interest is in changing perceptions of all women, especially Black women of African origin, African Americans, and many of the disadvantaged women. My other major goal or issue is that for me, breast cancer changed my life at the age of 74. So mine wasn't genetic or any of those things, it was just age, pure old age that created the cancer. But I was very lucky. I'm saying it's changed my life because if you hear cancer stories, you will not imagine that. Huh? Can you see my slide?
Yes.
Oh, okay. I thought somebody said something. Okay. You will not believe that I had yesterday actually was my 10th month survivorship of breast cancer. But when you hear the stories and woes of cancer, you will not believe that people like me after 10 months are still available now to talk and all this. I'm not typical. I better tell you that I'm a cancer survivor. Mine was caught between stage 0 and stage 1. So all they had to do was the mastectomy. I didn't go through chemotherapy. I didn't go through radiation therapy. So I'm saying that there was a message there. And the message there for me was to look deeper into cancer. And for the rest of my life, I'm devoting my time and effort towards cancer, especially breast cancer and cervical cancer that affect women. So if I do nothing else, I probably should be here to change your life or somebody else's. So these are the incidence of both breast and cervical cancer are high amongst women in Africa. And I'll give you some statistics in a few minutes. And my goal is really to just contribute a little bit towards the eradication of breast and cervical cancer, and especially amongst our own people. Charity begins from home. And most of my advocacy and interaction and work-related kinds of things are with cancer organizations and groups, from James Cancer Group at Ohio State, who actually did everything about my cancer, to Life Care Alliance, whom I'm also working with. And so, as I said, my thing is to make sure I empower the groups that are in the space in which I exist, and doing that is providing knowledge, creating activities, doing some community work and all that. And specifically, I'll be talking about prevention, mentoring, research and referrals. Okay, so here now we look at breast cancer. As I said, it's the most common cancer now in the world, and it's gone above lung cancer, which was leading cancer in the world before 2020. And now is the most diagnosed cancer in the United States. And you will see that every literature you will find is 1 in 8 people are most likely, are more likely all over the world globally to get cancer. And globally, every 14 seconds, somebody in the world is diagnosed with breast cancer. So it isn't something that we have to kid about. And the global breast cancer fact sheet for all sexes and all ages in 2020 were 11.7%. Can you imagine? You know, for a total of 2 million plus. And the number of deaths, 6.9 deaths for just one disease, okay, in 2020. Most of the data I got from Global Cancer Group, that is a part of the WHO, okay? And as I said before, it's 1 in every 8 people are diagnosed with cancer globally. And in 2020, more than 2.3, over here, I told you both sexes. Down here, I'm telling you about women. Women were diagnosed with breast cancer worldwide, and for 685,000 that died. Okay. And I told your president, Mr. Buki, that there are people that may be very interested in cancers across the globe and all that. So I have prepared you this slide, this, and the next slide I'm going to show you, and a few more slides that I will email to him. Then you can see links of where you can read about them. But today's presentation is actually focused on breast cancer awareness. Okay, and this is the second one I said you would, in fact, as this is pulling up, I will show you this breast cancer atlas. And this is coming from online. And the breast cancer atlas is something that you can use, like here in Nigeria. We can pull up Nigeria as an example of what we want to know, the data we want to know about Nigeria. And then we can also pull up another country like the United States, you know, and compare the kinds of cancers, whichever cancer we want to measure or think about, you know, we can do that, and compare country with country, and state with state, and even continent by continent. You can have all of that information. So I'm going to close. Sorry, whoever that is. So I'm going to close this and get back to our presentation. Hold on here. Trying to go back to this thing. So I'm going to go back to sets. So I'll give you the information on the breast cancer atlas. So if you want to know more and read more, and I'll give you the link, you can do that. But regardless, what we know now, our focus is breast cancer awareness. And the idea is at the end of the day to schedule screening, or have somebody you love or know go and schedule screening. Because we're going to talk about the breast cancer itself, your heritage, your gender, age, location, lifestyles, and much more. You know, so that's what we're getting ready to do. So now we finished introduction, we're back. We're going into the body of of the presentation. I'm going to pull away this thing, trying to make sure that we're not covering the presentations. I'll put it on this side. Okay, so the risks that we have to be aware of are risks that are genetic. So you have to talk to two sides of family about the genes from your parents, your father, your mother, and the genes. I put up a helical DNA also slide there, but it's part of what I will give you later. But the two major genes that are very important are the breast cancer gene 1 and breast cancer gene 2, that mutate in our breast cancer, in our breast genes. Okay, those who have that inheritance are more likely to get cancer. But let me make this very clear. Two things I want to give you as take-homes today, that everybody's at risk of cancer, man or woman, doesn't even matter. So, but we're talking about specific risks that make people either moderately high risk or high risk, okay? But everybody is at risk. If it's not because of where you live, it is because of your gender. If it's not because of your gender, it's because of your age or whatever. Okay, so if 1 in 8 people, you don't know which one, and any of the 8 of us would get it, if one would get it. So for that reason, for the fact that people have genes that cause it, you've all heard about Angelina Jolie. Immediately she heard and realized that her family has these kinds of genes. She went and cut off not only her breast, anything, and then nose, everything. She cut them all off, and I don't know how many of you know Katie Couric, about a year and a half or so ago, she was diagnosed with cancer, So it doesn't matter who you are, what profession you are in, or what you do, you can get it. So anyway, it's good to understand the genetics from your parents' point of view, and then your doctor can advise genetic testing, where you go to geneticists who will test you, and it can be tested through the blood or even sputum, So understanding that is very important. And if you need genetic counseling after the genetic testing, that's also a good idea to pursue. And this is the double helix of DNA. And I took one that looked like a breast. This is not breast DNA. I just took a helical image that looked like it, where this thing here may be breast cancer 1, and you see there may be mutation on it, and it's not here, or something else is here, but it's not over there, but it's just display. So, but anyway, as I said, we are all at risk of getting this thing, okay? Only 5 to 10% women and 5 to 20% men with breast cancer have inherited mutation. The BRCA1 and BRCA2 we talked about before. Otherwise, the major thing as we're talking about women's breast cancer, the factors that are notable include age. As I said, mine was cancer of old age, the genetics, menstrual history, having dense breast, and all these things. And again, this is a slide I'm going to give your president for you, because you look at all of these things and check out which ones are related to you and which are not. So for breast cancer then, and especially for women, you check your genetics. So that's one thing. The second thing you do is making healthy life choices, okay? And I put this slide here to visually represent your weight, your real physical weight. Although she's carrying weight, but the intent is to show that you have to avoid obesity or overweight, okay? So living healthy, making healthy life choices includes maintaining your weight, breastfeeding where possible, if you're a woman, if you're a man, not about that. But anyway, limiting alcoholic drinks, limiting the use of hormones, and exercising on a consistent basis. You will find that if you do these things, you're not only saving yourself from breast cancer, you're saving yourself from cervical cancer, you're saving yourself from prostate cancer, you're saving yourself from high blood pressure, hypertension, stroke, all of this, and even diabetes. Okay, so these healthy life choices are really very, very important. And you look over here for the basket of goods that you can collect from to make sure that you're doing something healthy. Then the third thing, the first thing we did was your genetic information, right? And the second one is your life choices, healthy life choices. And the third thing is looking at your breast cancer. This particular page is given in so many varieties by most cancer groups. In fact, the package I gave you today, those of you who are sitting physically at Carl Library, it has information. The colors here are for whites, but the ones I'm showing you here are for blacks. And I will insert in your slide again both slides. This is what you get, and then you use it and present the slides I made myself. But this is common. This is something, anytime you're talking about breast cancer, they'll give you this. So what you have to know is now looking at your body, the signs. Lump. My lump was right under my armpit on my right breast. Nipple that discharges, my nipple was discharging also on that particular breast. But I had that lump for 20 to 25 years. It didn't do anything till last year. So I actually had my lump for more than 20 years, but it didn't grow. But the method that I was always going for, a mammogram and talking to my doctor and doing all the necessary things I was supposed to do, made it possible for them to discover it. Immediately it came out, the 3D mammogram they used on me, immediately detected it. You know, the cancer was detected on the 21st of September last year. I didn't have surgery till December because it wasn't metastasizing, it was just in there, but it was detected in time. Okay? So you can have dimples, as I said to some friends, dimples, you see people with those in their cheeks, but when the breast begins to get dimples and getting, then there is problem. The breast or nipple may present pain, okay? Or the nipple itself may retract, just go inside and invert. Or you may have redness at some part, especially below the nipple. And there may be changes in the breast itself or lymph nodes. This one you cannot detect for sure. You will need a doctor and somebody else to do it. Or you have the breast itself swelling, okay? And so, as I said, this is the one for white people. It's the same thing. The language is a little bit different, but almost everybody who tells you something about breast cancer, especially screening and all that, will give you this information. So it's already made, okay? But then you will do the analysis and do your presentation. But what I'm trying to show you here again is another set of information guidelines for women with breast cancer. And what the CDC did was to compress information from all the different groups that work with women, whether they're working with women as mothers or they're working with women as family practitioners or whatever. They all have their own guidelines. And I must emphasize this, no two cancers are alike. Not even two cancers on one person on both breasts are alike. So everything is different. So many of these people are giving you guidelines based on their experiences, and you can just average it out and look at the guidelines. I will give you that slide also. I told you your president that I will give you that. But regardless of what it is, screening should start early, okay? Most people do not show symptoms, and those with high risk should begin. High risk now, we are talking about people who have BRCA1 or BRCA2 and should start as early as 40. And some may even start at age 30. Okay, and moderate risk at the age of 45. And they say once you're up to 55 years old, you should be doing cancer examination every 2 years. Okay, and then again, different screening guidelines may be available to you, and or for people who are not tested within a family, but who have families that have BRCA1 or BRCA2 mutations should also go and get tested. And people may have a history of chest radiation and all that before the age of 30 years. They should also go and get tested. And those who have a lifetime of breast cancer risk of 20% or greater based on their family history, should also go and get screening. One other thing one other information I'm trying to present here, I'll give you is that going and getting screening or getting all of this information in doing that isn't to frighten you or scare you. It is based on data. Early detection of breast cancer, any cancer at all, but breast cancer especially, since it's subject of our discourse. Early detection provides two things. Early screening and early detection. Early screening helps you to organize and rearrange and do all of those things we're talking about to prevent it, like lifestyle that changes. If you used to drink and all that, you change it. And early screening is one of the key points of saving lives. That's what saved my life. Mine was screened early. Okay, so if you wait and don't make that decision early enough, then you may not be here, where informed and shared decision-making results in benefits for both yourself and for the aggregate of the people or the population. So I'm going to conclude here. Conclude here means that thing I told you, I'm going to say them again, and then Dr. Awosika will say something, and then we will do the actual conclusion of questions and answers and all that. Okay, but what I'm saying to all of you is that you have to go and see the doctor. And you have to go and see the doctor while you are doing all of these 8 things at least. Maintaining a healthy weight, adding exercise to your routine, limiting alcohol intake, limiting menopausal hormonal usage. If you're a woman that can breastfeed your babies, eat healthy diet, be physically active, get screened early and often. I'm going to pause here so Dr. Awosika can say something about prostate cancer, and I think it is pertinent for the group. Dr. Awosika, please.
Thank you very much, Prof. And thank you very much for inviting us to this important day and inviting us to share something that is very, very important to both of us. I'm a prostate cancer survivor. I was diagnosed with prostate cancer 2006. And since then, I've been surviving. And if I can share my screen, I'll be very, very happy.
Yeah, Buki, please let him.
You can go ahead, sir.
Okay, thank you very much. You say I cannot. You have to give me.
Oh, hold on, let me stop mine for a minute.
Yes, you have to stop your process.
Yeah, let me stop mine. Okay, here, I stopped mine.
Does he allow you to share, sir?
Yeah, I can share now, yeah.
Okay.
Can you see my screen?
Yep.
Yes, we can.
Okay. Yeah. Thank you very much for inviting us to be part of you today. And as I said, I happen to be a prostate cancer survivor. And as Prof said, that the best treatment for cancer is early diagnosis. And according to WHO, 1/3 of cancers are preventable. Another 1/3 is curable. And the last third, if detected early, you can live a quality good life. And we have very good survival stories that I want to share with you of prominent people in the world. Nelson Mandela was diagnosed with prostate cancer at the age of 83. And one thing I tell people, if you're a Black person and a man, it's not if you are going to get prostate cancer, it's when you are going to have it. Being Black is a risk factor of prostate cancer. So he was diagnosed 83 and he lived 95 years, remaining cancer-free. Queen's mother, the mother of Queen Elizabeth, developed colon cancer at the age of 86, breast cancer at 83, and she lived till 101 years. And I think Prof too is going to live to 101 years too. Reagan survived colon, skin, and prostate cancer. And so it's survivable. Ruth Ginsburg was diagnosed with pancreatic cancer very early in her career at the Supreme Court. She lived for many years. So why is the situation different in Africa? That's the question we need to ask ourselves. And that's the question all of us need to ask ourselves here. Why is the situation different in Africa? Why do Africans seek treatment abroad and still end up dying from preventable cancers? These are the questions we need to ask, and this is the question we try as much as possible to answer. Annually, as Prof said, giving you statistics, 8 million cancers are recorded worldwide annually. Cancer kills more people than HIV/AIDS, tuberculosis, and malaria combined. And cancer is becoming an emerging public health problem in Africa. When I was in medical school in Nigeria, when we talk about colon cancer, we used to say it's an old man disease. Now you see people at age 40, 30 in Africa now developing colon cancer. And one of the issues that we find in Africa is that in some parts of Africa, prostate cancer in men and breast cancer in women have become the most commonly diagnosed cancers. I went to do a presentation, was it in Kenya or Nigeria? And someone, I think it was Nigeria, Abuja, and someone presented data to me that was very scary.
What is this?
About cancer.
The breast cancer.
Oh, okay. I think you said it goes somewhere.
No, I said I won't. Oh, sorry.
Yeah.
Sorry about that.
So we have many, it's a very, very, so why is it that we have problem of cancer treatment in Africa? The main reason is the stage at diagnosis in Africa. Majority of cancers in Africa are diagnosed at an advanced stage of the disease. And common reasons include this: lack of screening, limited awareness of early signs, as Prof pointed out today, symptoms of cancer among members of the public and healthcare providers, stigma associated with diagnosed cancer. And another thing that is very, very important that I would like us to consider is people saying, not my portion. This idea, not my portion, when you are diagnosed with cancer. Look, I'm a Christian, a born-again Christian. When I was diagnosed of prostate cancer, it was at the earliest stage of it. The Glenson scale was 6. That is something under you can watchful waiting. But I just looked at it, that I have a lot of things to pray about. I have a lot of things to worry about as human beings. Why should I be worrying about if I have pain somewhere I think is the cancer? So I said, okay, I made a decision that action should be taken, and action was taken. At that time, they put a radiation seed in it, brachytherapy, and today I'm okay, I'm fine, I'm doing well. So let's take our health seriously, as Prof suggested. And I'm going to share this data for us to see. I think you can see. If your prostate cancer, breast cancer, colon cancer, ovarian cancer are localized, the survivor rate is from 90 to 100%. But when it's still regional, it's still better. But when it's as metastasized, then you have hibernating tumor cells. These hibernating tumor cells, they hide themselves. So once you start treating that person with chemotherapy and everything, and the immune system of that individual decrease, these hibernating tumor cells, they come up with vengeance, and they are not responsive. They have different characters. So they are no longer responsive to the treatment that you are used to. So cancer survivor, and what we find out actually when we're looking at data is that the cancer diagnosis and cancer death, the ratio in Africa is 1:1. Whereas in developed countries is for every 3 or 4 diagnosed, only 1 death. That is 25% or less. But whereas in Africa is 1:1. By the time they are diagnosed, they die. So why is that? And that's the question we need to ask ourselves. The 5-year survival rates of breast cancer are less than 50% in Gambia, Uganda, and Nigeria, compared to nearly 80% in the United States. Why? These are the questions we need to ask ourselves at diaspora, and these are the things we need to communicate with our family members in Nigeria, in Africa. And the comparative cancer management is that early diagnosis. If we find cancer early, 90% of it can be cured. You can live with them with the rest of your life. But when you diagnose them late, only 10% is fortunate to survive after 5 years. The difference is so clear. So for the topic of today, which is prostate cancer. So what is prostate-specific antigen? Every organ in the body secretes protein. The prostate too secretes protein. So these protein, when they are denatured, are what you measure. The quantity is what we measure as prostate-specific antigen. That is, when you have too many of it, when the protein, every cancer is protein. It's uncontrolled protein secretion. So when you have more than expected in the blood, like where you go for your liver function tests, all those tests, what they are testing is your protein in the blood. Are they within normal? The red blood cells, everything, are they within normal? So if they are above the normal thing that you have, then they will ask you to go and do further tests. So the same thing is the prostate-specific antigen. We measure the quantity with the PSA and say, okay, if it's more than normal, then go and do further tests, go and do biopsy. So the question that I think you guys are going to ask is that, what is an elevated prostate-specific antigen level? That's a very good question. We are not settled yet on the actual one, because at the time I was diagnosed, my PSA was 3.1, and the normal level is 4.0 or higher. But other factors was responsible for my further diagnosis. They look at the every year I go for my PSA test. Every year I do record 1 point something. So this year it was 3.1. So the velocity increased. So it was that velocity, that increase in velocity of that test, that made my doctor to say, okay, go for further testing, go for a biopsy. And to be frank with you, that biopsy is 1 time too many for me. So it wasn't a very easy thing to go with. So my the surgeon told me that they can do watchful waiting, and I asked him, how will you be testing me every year? He said, we have to be doing biopsy. I said, no, that biopsy is one time too many. Let's just get rid of this problem once and for all. Do antigen, the PSA level determine if I have prostate cancer? As I said, there are other factors the doctor will look at. The level means higher risk of prostate cancer. Persistent rise, which was my own case, was what led to my doctor to say, okay, but the PSA alone does not determine whether you have cancer or not. Two men may have the same PSA level. I've seen people with PSA of 10 and they do not have cancer. 20, they don't have cancer. It could be due to BPH, it could be due to other factors. So what are the risk factors of prostate cancer? Your prostate level, persistent rise. You may be at higher risk of prostate cancer if you are over 50 years old. If you're over 50 years old, and if you are Black. I had mine before I turned 50. I was 40 something. You have a family history of prostate cancer. My grandfather had prostate cancer. So that's my family history. You have certain genetic changes that Prof discussed about, genetic changes. They are important factors too in that regard. So how common is prostate cancer in men with elevated PSA? It's common, but cancer is more likely when your PSA level is elevated. Below 4, where your cancer is, there's 15% chance of prostate cancer. Between 4 and 10, 25%. Over 10, 50% chance of prostate cancer if you do the PSA and not PSA. What are the causes of elevated PSA level? There are many causes, but when you have any elevated one, first thing about prostate cancer, it could be benign prostatic hypertrophy, that is enlarged prostate. It could be swelling or inflammation of the prostate due to infection. It could be due to urinary tract infection. It could be to maybe you had a catheter placed in. It could be to ejaculations, and it could be to bicycle riding, and some drugs can even cause that. Will rising PSA cause symptoms? No, but it's your prostate itself that will create symptoms like difficult urinating, frequent urination, even during the night, slow flow of urine, urinary incontinence, difficulty holding urine. So these are things you need to look out for. When you see this kind of symptoms, you go and see your doctor. Your doctor can do a rectal examination, digital rectal examination, and also check your PSA. And if all this goes up, then there are other tests your doctor will recommend for you. Your doctor can say, okay, based on that, go and do, let's look at the free PSA. You go and do the free PSA, and they look at everything, and they ask you to go and do a biopsy. So those are, and then there's a new test in the market now called ISO-PSA. ISO-PSA is a new laboratory test. It's developed by the inventors at Cleveland Diagnostics, which is an offshoot of Cleveland Clinic. They developed this technology. This technology measured the quality of the protein, not the quantity. Whereas PSA measures the quantity. This one measures the, so it see everything in 3D. And it's very, very specific for cancer, for prostate cancer. Whereas PSA is specific for prostate, but not for cancer. But ISO-PSA is more specific for prostate and prostate cancer. And it can be using this instead of going for biopsy. So it reduces the number of necessary biopsies. It's going to tell you whether you need to go and do biopsy for final confirmation. And it can tell you if you don't need to. So your doctor can use this to manage your situation. So up to 75% of prostate biopsy performed in the US are negative. And someone that went through the biopsy, I can tell you it's not an easy thing to do. But ISO-PSA can reduce the number of unnecessary prostate biopsy by up to 55%. So as from November 20, 2022, ISO-PSA will now be covered for millions of men enrolled in Medicare. Then as from January 1, 2023, every other insurance, whether non-necessary Medicare, will cover it. Personal disclosure. My company, DHMI Group Incorporated, has exclusive licensing rights to offer Cleveland Diagnostics cancer diagnosis technology in Africa, Caribbean, and Philippines. And the ISO-PSA is the first commercially validated test of their range of tests that they are putting together. They are putting one for breast cancer, for ovarian cancer, for pancreatic cancer, for uterus cancer, for Alzheimer's. So it's a very simple technology that they developed, and it's working magic. So question, thank you very much. Question and answer time. Thank you.
Okay, I need to pull up the other screen, the last screen, Dr. Awosika.
This one?
If you will stop share, I will pull up my last screen. Yeah.
I should stop sharing.
Yes.
Okay.
If you stop sharing your screen, I hope I can still put up. Okay. I have numbers there. I have phone numbers that they can get. You know, so let me try again to see if I can share this screen. Yeah, this screen. Okay. I volunteer to so many cancer organizations that are mostly local, but I sign up also for the American Cancer Society and all that. But there is one group here that pays attention to Black people. People in at the library should have a copy of this folder from Life Care Alliance. Life Care Alliance works mainly with Black people and disadvantaged people. So I gave you people handouts in these, and I includes a pen also. But what I wanted to say about it is that you can always reach them if you don't have insurance or your insurance is limited. They don't have the excuse of not having insurance or money for not getting screened for breast cancer. That's what the American Cancer Society says, that there should be no excuse for not getting screened for breast cancer, at least. So in Columbus here, you can go to them and their number, you can call them. I've given you the number. I changed this slide. Initially, I put my number, and then I said, if you call me, then I have to call them. So why don't you go straight and call them? They will do, and they do the 3D mammograms. So you won't be losing anything. If you qualify, they will do it. Whether you're in asylum or you know somebody who is in asylum or somebody who is a refugee or somebody who has never had insurance, you know, that should not limit you from getting screened. So, and my email is here, but please we open it up now for questions and answers, discussion. Sorry, we ran too much over time, but I think it is worth it. We don't know when we will schedule these kinds of meetings again. And the other thing that Dr. Awosika mentioned that you should bear in mind is the burden. You know, if our people get cancer, they are likely to die. Why is it that the numerical number, strength of the white people who get cancer is always more, but the number of deaths, the dead bodies, are more for us Black people? Whether it's Black, African Americans, or Blacks, and 40% more likely to die, because it is usually 1-to-1 ratio, as Dr. Awosika said, you get it, you die. But we are not in that group, and we don't want you to be in that group. That's the reason for this session. We will continue having, at least I know I will continue having these sessions. And as I said, please pay or donate to any cancer of your choice, cancer group of your choice. I don't collect money for any of these presentations or anything like that. I'm doing it as a public service.
Thank you so much, Prof. And thank you also, Dr. Awosika-Olumo. And I think these are very, we are recording, so we're hoping to also put this on our page for future view. And I will share that with the presenters also. But at this point, I think it's open for questions. It would be nice to have those questions. I think Prof just threw something out and talked about how much Caucasians or so actually have more occurrence of cancer, but the Black heritage actually has more cases of death and mortality from cancer. And I think the presentation has talked about early detection, information, and a couple of those things. And of course, let's feel free to share the same message with our friends and family. But again, as you've heard them, Prof and Dr. Awosika are both cancer survivors. So we celebrate you and we thank you so much for sharing. But at this point, I'll stop. Any questions at all, and they'll be able to do justice or reach out again to us. Any questions? Feel free to jump in and ask those questions.
Yes, I do have a question for Prof.
Yes.
Please, ma'am, you mentioned men while explaining breast cancer. I just want you to kindly brief us more how breast cancer affects men in a way.
Okay. It affects them from two perspectives.
Okay.
The BRCA1 and BRCA2. There are men that have that gene. Well, actually, it's supposed to be a gene that is found mainly in women, but some men do have it. Okay, and if it mutates, that could result in cancer.
Okay.
The other thing is any of those other variables we talked about, any of there are men who have dense breasts. Okay, they are dense as women's, but we don't know why. Maybe it's hormonal issue or whatever. There are men who don't exercise. Okay, there are men who grow old. I know two people who have been at a James cancer treatment program. They have cancers, breast cancers, and they come into the same clinic that I do. You know, so you don't know and I don't know. But if you do any of or all of those things that we say you should do, living healthy lifestyles and all that, you're more likely to prevent it. Well, when age comes in, even if it kicks in, because you have already preconditioned the body, ask people who know me from my family, even my grandchildren, they know I'm a health fanatic. Anywhere I see a spa or whatever, I sign up. Okay, anywhere I can do exercise, I will bicycle, I will walk. I do even, before I got this breast cancer, I was doing like 10,000 steps a day after going to the gym for about 2 or 3 hours. So I don't know how or why I just decided I would do this. So when the cancers, I'm a living example of the benefits of those kinds of things, because when this cancer struck, it wasn't deadly. You see what I'm saying? Because the body is already conditioned. I had the lump for over 20 years. Can you imagine? And then when it decided it to become cancerous, it couldn't metastasize before it was discovered. Because I was always going for mammograms, I was always good. So back to your question about men, we don't know. We don't know. That is why we say, do all of these things. So even if it comes, right, it won't be very hard. It won't be very harsh, and it won't kill you. And we don't want cancer to kill you because of ignorance.
If I can just chip in there too.
Thank you.
Yeah.
Thank you very much.
If I can just chip in there too. Men do have breast cancer because they have breast. That's a simple question. But cancer generally, we need to understand one thing about cancer is that uncontrolled protein secretion. So there could be a genetic change. Anything can change your genetics. We create an uncontrolled protein secretion that is beyond what your body can eliminate. We have a regulatory system in our body that regulates the proteins. And I mean, the die and the get off, you get them out in your urine, sweat, and all those kind of things. But at times it's overwhelmed the ability of the body to auto-regulate, then it becomes a lump. So that is where it's formed. So that's why early diagnosis is the best treatment for cancer. Thank you.
Thank you, sir.
Thank you.
Thank you, Prof. I'm grateful.
Welcome. Thank you. We need more questions. I'm sure there are things running in your head.
I have a question for you.
Oh, sure.
Does breastfeeding relate to cancer, breast cancer?
Yeah.
In other words, do women who breastfeed have more chances of having cancer than those who don't breastfeed and just depend on what do you call it?
Yeah, if I can just come in, I understood what your question. Let me just come in.
Let me just point him to
I will explain. Let me just explain it to you.
Okay, go ahead.
Breastfeeding is preventative. So when a woman breastfeeds, like the density of the breast is reduced with breastfeeding, which is one of the risk factors of cancer. So, and then when you do breastfeed, there are certain hormones that are secreted that are counter to what can stimulate breast cancer. So based on that, breastfeeding is protective. From all studies done, is protective of breast cancer. Yeah.
Did that make sense to you? What he's saying is part of what I already had in a slide, that part of the healthy lifestyles is if a woman who can breastfeed. And one of the things that Awosika-Olumo had already said to you is in terms of if you even think of diabetes and insulin control, the proteins that are produced by these cells are not controlled. The regulation goes haywire. But you see, what is it that is the protein that is it? The cells are metabolizing, not only metabolizing, that is using up the oxygen and everything else, the nutrients that you've given them, but they divide. What is cancer? Unregulated and unrestricted division of the cells. So the cells, these cells that you remember our DNA that I showed you, double helix, it opens up, then it divides. But those genes that are there that are mutating, rather than just replicate what they had before, they go haywire. They just replicate something else, and that thing replicates something else, and that thing replicates something else. Okay, and the proteins eventually that are produced, because your cell and my cell, or in that particular part of the body, do not have the regulators to kind of control this excessive division of cells. You know, so the proteins that are produced are just accumulating there. And so when you hear metastasis, that means that these bad cells have because they start moving all over the body. They start even into the brain. Okay, they move in your bloodstream, they move anywhere. We're lucky as stationary. They were at the bus stop, at the train station, and they were captured there. They couldn't move, they couldn't fly, they couldn't do anything. But when the body loses control of these things, and the body is wonderful. Just think about the control of how you and I sleep, wake up every morning, and we're still able to function. All it needs is just one cell. One gene, I'm not even talking of cell, to just misbehave and say, I'm not going to follow all the regulations. And that's it. So when you breastfeed, those cells that are supposed that breast cancer, even if you had them, they are not going haywire, they're not multiplying out of control. Okay, and all the other cells, the regular cells, are not misbehaving also because the breast is less dense, right? Because you're pumping out all that breast milk and feeding the baby. So you are protected as a mother who breastfeeds more than a mother who gives her children bottles. Does that make sense? Well, yeah, we're not going anywhere. The sun hasn't set yet. You guys want to go, that's why. But we're here, no, seriously, because we think this is a very serious problem because it's either tradition, taboos, marriage, and the patriarchal societies we live in, where the men sometimes determine what the woman has to do with or without her body. And religion, these religious groups that have fled all over the place. Go and talk to people in Nigeria. And I think Dr. Awosika mentioned that earlier on, you're born again, and this is my portion, this is not my portion. Whose portion is this? I mean, just make sure everyone gets their own correct portion. So why tell me which one is your portion, which isn't yours? You don't know. You do not know, and I don't know. So don't tempt God by telling him what is your portion and what is not your portion. Do the right thing and you'll be safe. And you know what? People who have cancers also have some good percentage of those who have had it once are likely to have it again if they don't take all of the precautions. And even if they take all of the precautions, they may have it again. So it isn't like once we've gotten it now, we can't get it again. But we'll still have to be doing the right things we think are necessary, to make sure we reduce the potential or the incidence of recurrence.
Yeah, and if I can come in here, I think I was in Kenya, either Kenya or Burundi or somewhere where I was doing presentation. And
Prof, can you hear us?
Yeah,
can you hear me?
hearing you. Yeah, let's look at the chat.
Okay. Is anyone asking a question?
Oh, no, I thought it was a question that somebody had to leave. That's fine. It doesn't matter.
Okay.
Go ahead.
So,
Go ahead.
And the question that someone asked was that, what is the essence of diagnosis if they can't manage, they don't have resources or facilities to manage the cancer? And the answer I gave to them is simple. At the time we diagnosed cancer in Africa, even in US, it will be difficult to manage. If we diagnose cancer early in Africa, you have surgeons that can remove the offending organ at early stage. If it's the breast, remove the breast. If it is the prostate, remove the prostate. If it is the colon, cut that part of the colon, tie the other, remove the polyps. We have surgeons that can do that in Africa, and it's less expensive at that stage. But at the time we diagnose cancer, it's already late. So in US here too, people diagnosed at that stage, they die because most of them, after they've been diagnosed in Africa late, they come abroad here, they come over to US, they go to UK, they go to everywhere, and at the end of the day, they die. Within the period, they will have died in Nigeria. And some cases, even when I was practicing in Nigeria, some cases that I do see, they are very sickening. We saw a lady who had breast cancer. We said, okay, this is what you need to do. She disappeared for about 6 months. Went to all these prayer houses and everything. So she came back 6 months later. There were maggots in the breast. So these are not good stories. And this is one of the reasons why I like doing presentation of cancer in African groups. In African groups, because we need to get educated about this thing. Look, I'm ready. Look, my family, my grandfather had prostate cancer. 3 of my aunts had breast cancer. They died of breast cancer. So I know, the 3 of my direct aunts of my grandmother, grandfather, 3 of them died of breast cancer. I had a first cousin that died of breast cancer. And that's one of the reasons why I said, look, I need to do something. And God, as God is so made it possible for me, had my prayer, brought me in relationship with Cleveland Diagnostics and Cleveland Clinic, that I become the ambassador of educating people about cancer, early cancer detection and early cancer diagnosis. So if there's anything you are taking away from this meeting, from this conference, is early detection. If there's anything you are going to take from it, early detection. That is the key. Early detection is the key. And once you are detected, when I was diagnosed, I had the opportunity to make my decision of what I wanted. I was diagnosed around the summer of 2006. I didn't do my procedure until maybe spring of 2007. And while I took time to make the decision that would be best for me, there are many opportunities there. I could have done radical prostatectomy and look at the pros and cons and everything. I looked at external radiation and look at internal radiation, brachytherapy. And I came to and decided, okay, this is what I need to do because I have a luxury of making that decision. I have that luxury. So why we should all be exposed to that. As Black folks, let's start telling our people they need to go for testing. If you are here and you are hearing my voice and you are a guy and you've not done your, you are with over 40 and you've not done your PSA test, go and do it. Please, go and do it. I'm begging you. Go and do it. And one thing we have to understand about morbidity mortality in Africa is that every African man feed at least 11 children. So the number 1 cause of poverty in Africa is death of men. Please take that very serious. And if you are a man or woman listening to us today, please go and do the appropriate test. women, breast cancer, men, prostate cancer, and when you get over 50, colon cancer. Thank you.
Thank you so much, Doctor, and thank you so much, Prof. Are there any last words, and we can wrap up at this point?
Yes, let me say also that we cannot use money or lack of information. I'm open to any and everybody who can reach me 24/7. Pick and choose when you want to call me or relate to me. But the most important thing is that we also have groups who can take care of these things at early age. So what does it take for your cervical cancer, which I mentioned earlier? Just a pap smear. Okay, and I said before, they can do this very quickly and easily. And you can couple it with going for the breast cancer examination mammogram. And people who do one usually do the other. And in fact, you can also couple it with regular checks for diabetes or hypertension. Because these are also diseases that are killing our people. And if you look at them and look through them, they're diseases of omission most of the time. And of course, then presentation. We don't go and present till it's very late. So try and couple any kind of screening visit or visitation you have with the other one or the other things. They're more likely to be less expensive and more beneficial to you. Thank you.
Thank you so much. And I will stop the recording so we can actually have this well put together for today. But thank you all for joining. A couple of people had to drop off also because they ran out of time. But other than that, thank you. Thank you.